First speaker is a very dynamic speaker, Dr. Sushmita Kaushik from PGI Chandigarh, who is going to tell us definitive medical management outline, planning the upscaling of the treatment strategy. 6 minutes is what you have. You have to be hit the bullseye.
Looking forward to Sushmita's talk.
Thank you. Is the slide visible now?
Yes.
Yeah, okay. I'll just make it full screen. Yeah, is that clear enough?
Yes.
Right. So right at the outset, thank you, Dr. Chitra, and thank you, AIO. It's great to be here. So this is just upscaling treatment strategy. So I'll try to finish in 6 minutes on the dot. So the fundamental goal of treatment is to slow the rate of cell loss to an age-dependent rate. And this is something that we must understand, that as we go down the line and down the life of a glaucoma patient, we've lost a lot of battle. So that's one reason to catch them and treat them early to get it back. In spite of it being a multifactorial disease, lowering intraocular pressure helps all types of patients. So whether you're high tension, normal tension, or ocular hypertension, all our landmark trials tell us that we need to lower the pressure. And how much we need to lower depends upon what the initial pressure is, the stage of disease, the life expectancy, the rate of damage, and the corneal thickness. But at the end of the day, we need to maintain functional vision throughout the patient's lifetime. That's what we need to understand, rather than get it down to this or that number. And we also need to think about the patient's quality of life. So more than 50 years ago, Paul Chandler said it best: eyes with advanced glaucoma require a pressure below the average. Eyes with limited cupping confined to one pole appear to withstand pressure better. And eyes with a normal disc, which is ocular hypertension, appear to withstand pressure well over many, many years. So at the end of the day, we are not treating the patient, we are treating the pressure, we are treating the patient. We usually start with a prostaglandin analog because they have maximum intraocular pressure lowering as monotherapy. They have effective diurnal pressure control. There's minimal tachyphylaxis. It's convenient to dose, and there are few systemic safety concerns. So we've got beyond what we should start with. Now, the initial monotherapy, we look for at least 20% reduction in IOP, and if they are responsive, there are two things: either the treatment goal is not reached, or they're unresponsive. Now, if the treatment goal is not reached, we have either a fixed combination or an unfixed combination, and this is where the story starts. But periodically, we need to verify the pressures, the fields, the optic disc, as well as the quality of life as we go along. Why would we like monotherapy? Of course, there's better compliance, 49% with one medication compared to 32% without. And why monotherapy? Again, the washout effect is eliminated. So if you have a 30-second interval between, 45% is washed out. So if you give them 2 drops and they don't have too much time, within 30 seconds, half of one drug will be out. With a 2-minute interval, about 15%, and with a 5-minute interval, maybe not. But then it's a very rare patient who would agree to your 5-minute between. What is the problem there? The problem is that prostaglandin analogs don't always lower the pressure as much as you would like, and nearly 1/4 require additional drug within 1 year of starting treatment. So that's the problem. You need to give 6 weeks time to all PGAs and expect a 30% reduction from baseline. But then if it's less than 20% for a PGA, we need to switch to within the class. So that's the first upscaling. If a PGA does not reduce pressure to at least 20 to 25% from baseline, switch within the class before adding. Now, if you've done that and it's at least 20% reduction and yet it's not what you want it to be, then the treatment goal is not reached, and then you need to add, whether it's fixed or whether it's unfixed. Once you've decided that the second is needed, the factors to keep in mind is efficacy. You need adequate additional lowering, at least 15% additional. So you need 15% over and above what you had with your 20%, and the complementary mechanism of action to a prostaglandin analog makes sense. You need to look at safety and tolerability with minimal systemic adverse effects and the convenience of dosing as well. So the choices we have are beta blockers, alpha-2 agonists, topical CAIs, myotics, and combinations. So combinations, most are with timolol, whether it's dorzolamide or brinzolamide, and dorzolamide with brinzolamide the efficacy is equivalent to separate bottles, but the advantage is no timolol, which is advantages maybe some patients like normal tension glaucoma. There are new kids on the block, the Rho kinase inhibitors, ripasudil and netasudil. We are still evaluating how they work, but initial reports seem to suggest that netasudil works a little better and is a little better tolerated. So the advantages of fixed commonsensically dosing is 1 drop versus 2. Convenience will always help patient compliance. There's no risk of washout from the second drug, and there's possible cost savings. It's not that there aren't challenges. So the concept of persistency impacting factors, this I found a very, very interesting draft. So it says that if it's ideal, then it would be 100% compliant if there's nothing else. But then we are humans, we're not robots. So after human complacency or denial, it drops to about 80%. With complicated dosing, it would drop further. With added side effects, it drops to about 50%. And if you have economic issues, it drops to about 40%. So it's not just enough to know that a drug is working or the reduction is enough. All of these are human factors and other factors that we need to think about before we start with or insist upon medication. So coming to the side effects, you can have side effects of preservatives. These are all preservative side effects, typically follicular conjunctivitis. And the most common cause is benzalkonium chloride. But then you can have side effects of the antiglaucoma drug itself. So this is by brimonidine, the periocular pigmentation and the dryness. And this is, of course, Lumigan or bimatoprast, which we've all seen. You can have these really long lashes, so we avoid it in case we need to give it in one eye. So rule of the thumb now is about 2 bottles and not more than that. Medications, laser and incision surgeries, remember, are all effective in lowering intraocular pressure. PGAs consistently are superior in IOP lowering as well as adverse effects, and patients treated medically or surgically are less likely to experience progression of visual field. Thank you so much for having me on. Thank you.
Yes, you covered it all. So I'm stuck about asking questions. But if you have a long-term drift with a timolol maleate or a prostaglandin, what will you do?
So if they've used it for a long time and it doesn't seem to work as much, first for prostaglandins, we would switch within class.
Yes.
And with timolol, we would have to switch the drug because we don't have any within class as well. But it happens very commonly. We've seen it happen with all 3 classes. So I can't say which one has more of a long-term drift than the other.
So you said that beyond 2 drug combinations, you won't go to the third. So then when would you use your ROCK inhibitors? I thought it's a third-line management.
See, the usual thing what we've seen is that if the patient has to use more than 2 bottles, and 2 bottles means at least twice or thrice a day, which makes it about 5 to 6 drops a day, that's almost next to impossible. So 2 bottles would include a ROCK inhibitor, but if I've gone beyond 2 bottles, I'm already telling the patient that, look, we might as well think of surgery. Nowadays, we have options of laser trabeculoplasty, we have options of ab interno surgeries, they work well, the GAT works well, if not completely, at least in bringing down the requirement of medication. And if we are planning cataract surgery, many times now we combine it with maybe a GAT or a gonioscopy assisted transluminal trabeculectomy or maybe a trabectome, since we have it now. And we are very happy with our cataract surgery patients, we brought down medication. But usually people don't tolerate more than 2 bottles with or without the netasudil.
Dr. Satya, do you have any thought? You have to share your screen though. Yeah. On what Dr. Sushmita said, anything different?
Yeah, it's very true. We all give the medications, but unfortunately, we don't really understand how much of difficulty the patient goes through. Give 3 bottles, 4 bottles, it's just not possible. Even if they are old age, even though they are sitting at home, it's just giving, you may feel comfortable, the IOP has come down, but what we have to think about is the quality of life and how much he has to spend for each of his medication. That's not easy actually.